Hey everybody, in this video we are talking about chest tubes, Heimlich valves, and the Pleurovac gravity drain. These are all maintenance of established devices level 2, which is a core delegation for PCPs and ACPs, and is not available to the EMR. So first things first, this is a chest tube. It's a sort of a flexible plastic, and the tube is inserted into the pleural space, and the idea of it is it's to drain air or fluid that may have entered the pleural space. So for example, a pneumothorax or a hemothorax. So you can see here at the end it's got some holes in here that allows for drainage, and there's also one on the very tip. It has a graduated lines here to tell us how far the catheter was inserted into the chest. So a good idea to take a look at those numbers when you come across a patient with one of these, so you can see how deep it is into the chest, and record that number. That way you know if for some reason it was pulled out of place. Okay. It also gives you the size. So this one here is a 28 French, which is a common size for adult males and adult females. And at the very end, there's a connection end that would be inserted into your Pleurovac line or into your Heimlich valve. So some of the indications for a chest tube is evacuating air or fluid from the chest, such as in a pneumothorax or hemothorax, preventing air or fluid from reaccumulating into the chest cavity or mediastinum, helping to reestablish and maintain normal intrathoracic pressure gradients, and then facilitating complete lung re-expansion to restore normal breathing dynamics for patients whose lung has collapsed in, again, a pneumothorax or hemothorax. As far as maintaining a chest tube, we want to make sure that it doesn't get dislodged. So as I mentioned earlier, good idea to note the number on here to see how deep this was inserted. You want to ensure that the drainage system that it's attached to is kept below the patient's chest when it's a Pleurovac or a gravity drainage system. The Heimlich valve can be placed anywhere on the patient. Avoid loops and kinks in the tubing that's connected to this, and prevent any obstruction. So if the tubing does become obstructed, we want to transport emergent to the nearest facility, because now we've created a closed pneumothorax, which can worsen the pressure inside the patient's chest. So chest tube drainage is either passive or active, and maintenance of established devices level 2 is passive drainage of the chest tube. So that would be by gravity using a Pleurovac or using a Heimlich valve. And a level 3 would be with suction. So for the purpose of this video, we'll be talking about the passive systems. And passive drainage includes the Heimlich valve, which we'll talk about later in the video, and a gravity drain, which we'll also talk about later in the video. But both of these provide a one-way seal that allows air to exit the pleural space and slows the reverse air, or actually completely inhibits the reverse of air back into the chest cavity. So the next thing we'll show you is what it looks like when a chest tube is inserted in a patient's chest. So here we see the chest tube in place in same man's chest. And what they'll do is on the affected side of the chest, so in this case it's the patient's left side of the chest that's been affected, they'll make an incision in the fifth intercostal space in the mid-axillary line. And they'll dissect the muscle layer, and they'll get into the pleural space. And once they're into the pleural space, they'll insert this tube, and they'll go up if there's air, and they'll go down if it's a hemothorax or if there's fluid. Then the tube is tied to the skin with suture, and here we have one suture in place, and I'll bring the camera a little closer so you can see it. So we have a suture in place to hold the tube there. You may see more than one suture depending on the situation, and that helps to seal the skin around the tube and create that connection. The other end of the tube would never be left open like this, because now we've just created an open pneumothorax. This will be connected to a drainage system or to a Heimlich valve. So here we see this is a Heimlich valve, and essentially what it is, it's a one-way valve. You can see inside it's a glass or a plastic tube, and inside is a rubber valve that closes on itself. So as air enters the blue section, air can exit out, so there's a flow direction here, but air can't make its way back up in here. So it kind of looks like the tip of a whoopee cushion, and it allows air out but not back in. So what you'll hear, if you do hear air squeaking through here, is it makes a light honking noise, kind of like a duck call. And this is sort of a temporary measure, and you'll see it connected to the end of the chest tube like so. And they'll snip this to make it fit nice and tight, and air can escape, but it can't come back into the chest tube. So this is kind of a temporary measure, and occasionally you'll see them set up like this, and you'll see just a drainage bag attached to this end here. If there is blood coming out, then it can drain away, and then air can be released, but it can't make its way back into the chest. So that is a Heimlich valve. Pretty simple little tool, but very effective for short periods of time. So another time you might see a Heimlich valve in use is for this setup. So this would be when someone has performed a needle chest decompression. So let's say it's a smaller hospital and they haven't put a chest tube in, but they needed to decompress the chest. They may have decided to do this this way. So they'll insert an IV catheter into the chest, and they'll decompress the chest that way. And if they're going to put this on longer term to transport a patient, they'll pop this onto a Heimlich valve. So how this works is the plastic catheter is left in the chest, and it's attached to some tubing that has a lure lock on this end and a similar to an oxygen connection on the other end. And that attaches to the Heimlich valve. So as the patient takes a breath in, the lungs expand. That pushes air out of the chest and out through the Heimlich valve, and the Heimlich valve prevents the air from making its way back in. So in your patient with a closed pneumothorax, tension pneumothorax, this is a setup you may see from a hospital to transport to a regional center or to Winnipeg. So again, similar to the chest tube, the air comes out. You may hear a sort of a honking sound coming out of here. It's a faint sound, but you may hear the sound coming out of there. And this is often taped to the patient's chest or to their side, and ultimately it doesn't matter where they position the Heimlich valve, it will function regardless. So there's no need to worry about it being lower than the site or higher than the site. It works no matter where it is. So that is the Heimlich valve used with needle chest decompression. So the final setup would look something like this. So our catheter's in place in the chest, and they'll often use roller bandage or something around it to keep this from getting knocked around. And we have our tubing that connects to the Heimlich valve, and they'll often tape this to the patient's side or to their chest or to their abdomen, and that allows for air to exit the chest and not to come back in. So this is a Heimlich valve with needle chest decompression. So as far as maintenance of this goes, again, the Heimlich valve, it doesn't matter where it is positionally in regards to height versus the site of the IV catheter in the chest, and same thing goes for when a Heimlich valve is used with a chest tube. It can be higher or lower. What we're concerned about here is that we don't lose any connections. So we want to make sure the IV catheter stays in place, which is why we have it secured here. We want to make sure our connection to the IV catheter is firm, and we want to make sure our connection to the Heimlich valve is firm so that air can't be reintroduced back into the chest cavity. If you do see blood coming into the line, that could be a sign of a hemothorax. It's not a huge concern. We should note how much blood loss we've noted, but occasionally you will get blood draining out of this if the patient does have blood in the pleural space. So the main thing is making sure all our connections are in place so that air can't be reintroduced back into the chest cavity. Okay, here we have only a couple things here that we want to keep in mind is we want to make sure the Pleurovac always stays lower than the site of insertion of the chest tube, and we want to make sure that there's no loops in our line. So similar to an indwelling catheter, we want to make sure there's no loops. Okay, so those are two things we want to make sure that we maintain as far as having this thing attached to the stretcher. Alright, so here we see the Pleurovac Sahara gravity drainage system. This is also a suction drainage system if suction is attached to it. But for the purposes of the maintenance of established devices level 2, we're going to be talking about gravity drainage. So it starts way at this end with a connection hose, And this hose is what's actually attached to the chest tube that's in the patient's chest. So you can see it attaches like this, and of course this goes into the patient's chest and is attached to the hose here. So the hose is connected all the way to the top of the Pleurovac right up here. So we see this sort of corrugated tubing here, and that's where that hose leads to. The corrugated tubing is tied to the first tube I showed you by this clamp. So this is a spot we want to make sure there's a really good connection here, that these are in solid. We don't want them to come disconnected at any point during the transport, because now air is going to be able to enter into the patient's chest. So really important that these are clamped together nice and tight, and wouldn't be out of the realm of absurd to put some tape around here to make sure that stays in place. Furthermore, this connection where the chest tube goes in place, we want to make sure this is nice and tight as well, and that doesn't come dislodged during transport. Otherwise, again, air will be able to enter back into the chest cavity. So make sure this connection is tight, and make sure this connection is nice and tight. Further down the tube from the chest, there is a clamp, but we do not want to use this clamp. This clamp would only be used in very specific situations which wouldn't apply to us. And keep in mind that if this is clamped, or if any part of this tubing gets kinked, we actually create a closed pneumothorax, which would lead to a tension pneumo, and that would quickly make our patient deteriorate. So we want to make sure this clamp is not squeezing the tubing off. You want to make sure your tubing anywhere along the line is not being kinked off, not caught in stretcher, the patient isn't sitting on it. You also want to make sure there's no loops in this, and that the Pleurovac itself is lower than the site of insertion of the chest tube. Here we can see the top of the Pleurovac, and I'm going to go from right to left here. So on this corner I've got the tubing that kind of connects to the patient. You can see this corrugated tubing that connects to the chest tube. Again, make sure this doesn't get kinked or clamped. Right beside it here is the high negativity relief valve. So this would never be used in a drainage system using gravity. You would only use this with suction, which is a maintenance of established devices level 3. So when this is being used by gravity, you want to make sure not to press on this relief valve. The reason being is it can actually cause a pneumothorax. So you want to keep your fingers off of this one. Right here is a needleless injection port, and this is where the nurse or physician, prior to your arrival, they're going to inject sterile saline or sterile water, and what that does is it actually fills the air leak meter, which we'll talk about later on. Otherwise, there's really no use for this thing here. Right beside it here, this little hole is a positive pressure relief valve, and I'll bring it a little closer so you can see it. When this is being used by gravity, it's really important that this doesn't get obstructed by anything, because that actually helps relieve positive pressure buildup within the Pleurovac. So we want to make sure that stays unobstructed. Right beside it here, you can see there's a suction port, and if this device is being used with active suction, then this is where the suction tubing will connect to. If we're using this with gravity, we want to make sure this stays unobstructed as well, because it will help relieve pressure in the Pleurovac system. So these two guys here, you want to make sure they're unobstructed. And this is another relief valve here. Same idea, make sure it's unobstructed when we're using this with gravity. So these three guys here, unobstructed when we're using gravity. This suction port would only be used with active suction. Again, a maintenance of established devices level 3. And this negative pressure release valve, make sure we're not touching that one when this is being used by gravity. At the bottom of the Pleurovac is a stand, and if we rotate it, it locks in place. And this is used when your stand is just sitting on the ground, not when it's hooked to your stretcher. So it prevents it from toppling over in any direction. It wobbles, as you can see, but it actually doesn't fall over. So that's a handy device to use when you're not hooking this up to the stretcher. And it can be put back in position like this to hook it up. We're going to look at the front of the Pleurovac here. We're going to start at the top left-hand corner. And this is most of the suction section of the Pleurovac. So this section would be more important when we're actually using active suction on the Pleurovac. So there's a control dial which won't be touched when we're using this with gravity. And there's a little float window here. You'll see an orange float that'll pop up. That'll only pop up if this is actively attached to a suction machine. With gravity drainage, this orange float will not pop up at all. And there's a negative pressure indicator over here, and that negative pressure indicator lets us know if there's negative pressure within the device, and that will only pop out if there is active suction in place, and may intermittently pop in and out with gravity drainage if as the patient takes respirations. So overall, this section, there's not much to touch or worry about when we're using this by gravity, and we'll talk about this in a later video when we get to the established devices level 3, which has active suction. We move down to the bottom left-hand corner of the front of the Pleurovac, and here we can see the air leak meter. So inside this section of the Pleurovac is a one-way check valve. So it allows air to exit, but doesn't allow air to enter back into the Pleurovac. You don't need water to create a seal here. But what the water is used for, and you can see it in here, it's got this blue color. What the water is used for is to detect air leaks from the chest cavity. So if you see an air leak in the chest cavity, you're going to notice bubbles. And we're going to see if we can create an air leak here. The more bubbles you see, the greater the degree of leak. So this is what it would look like. So that would be a small leak. And a large leak, of course, you would see bubbles go all the way across. So we'll see if we can generate that. So seeing bubbles in the air leak meter tells me there's a leak in the system somewhere. So whether it's a chest tube that's come dislodged, a connection port that's come dislodged, or maybe the tube has come dislodged slightly from the Pleurovac itself, somewhere along the line there's become an air leak. So when we're seeing bubbles in the air leak meter, we want to go from the patient back to the machine and see where it is that that possible air leak might be. Oftentimes it's usually a connection somewhere between the tubing that creates the air leak, a slight air leak. Occasionally it could be a rip or a tear in the tubing, in which case we're going to need to have that replaced. So if we are seeing air leaks, we're seeing bubbles in the air leak meter, it's important that we check to see where that air leak may be coming from. Otherwise, we shouldn't notice any air leaks in the system. The other thing we'll see here is this guy right here, which is what they call a water seal. And what it does is actually just gives you an indication of changes in pressure. And you'll notice it go up and down with respirations. So we'll see if we can generate it here. So you can see with changes in pressure, between negative and positive pressure, we get an indication here in this window. We move to the right side of the front of the Pleurovac, and this is the collection chamber. So we can see it's kind of a graduated cylinder here, and when this thing starts to fill, if there's, let's say there's blood in the pleural cavity, it'll start to fill in this corner here. So starting at the 10, you can see how it grows up gradually to 100 and up to 200. Once the patient has released more than 200 cc's of fluid, it'll actually spill over to the next chamber. So then we'll see it start to rise on this side. So we can see 300, 400, 500, all the way up to 1,000, and then it'll spill over to the next chamber, and then again to the next chamber after that. Maximum capacity in a Pleurovac is 2,000 cc's, so this can take 2 liters of fluid. Once this has reached 2,000 cc's, this is going to have to be changed, and later on in the video we're going to show you exactly how to do that. So here we have about 500 cc's of fluid that's been drained from the Pleurovac, And with gravity, this would fill up on its own, but since we're doing this in a simulated setting, we've got this hooked up to suction. So this is just to demonstrate when the fluid overflows that it goes on to the next compartment. So if you watch here, you'll see fluid start coming as I turn the suction on. So you can see it overflowing from one compartment down to the other, and you can see how now it's starting to fill up here into this bank. So as that continues, and this is filling up really fast for the purpose of the video, as this continues, it's going to overflow and go into the next compartment, and we'll watch that happen here. So you can see how it spills over to the next compartment and starts to fill. And of course that would continue filling until we got to the next compartment. Of course this was a really fast fill for the purpose of the video. You wouldn't expect to see such a quick fill in real life. But when we get to a completely full chamber of the 2000 mLs, we're going to need to change out the Pleurovac. So here you can see we have a completely filled Pleurovac, and when we run into this situation, we're going to need to change this up for an empty one, and we'll show you how to do that next. So I have a patient here with a Pleurovac in place, and the Pleurovac is now filled the full 2000 mLs. So if the patient is still draining, which in this case we have to assume they are, we're going to change out this Pleurovac for a second one. So best course of action here is to get your second Pleurovac set up right away. So we're going to hang a fresh one here beside it, have it ready to go. You can see it comes with the tubing already in the plastic. Remove it from the plastic, and you can see on the end of the patient tube there's this cap, this yellow cap that keeps this sterile. So we want to keep that cap on throughout this process to keep this clean, because we want an aseptic technique when we're connecting to the patient's chest tube. Okay, now that we have the new Pleurovac hung and ready to go, it's time to change the patient's chest tube from the old Pleurovac to the new Pleurovac. So timing is the key here, and we want to do this quickly because as soon as I remove this tube from the patient's chest tube, we're creating an open system. So I need to have my new tube close by and ready to connect to right away. So the quicker we can do this, the better. So the best way to do this, we can see I've got the patient draped here. We want to keep this area clean. You want to get a hold of the chest tube itself with your dominant hand. And you can see I'm holding both the old tube and the new tube with my non-dominant hand. So we want to keep this tip clean. So I'm going to remove this cap and keep it held away from the system. I'm going to remove the chest tube, and I'm going to connect it right away to the new tube. So now the old tube, the dirty one here, can be discarded. And I'm left with just the new tube connected to the patient's chest tube. So now that this is in place, the patient is safe again. Air can exit the pleural space, but it can't make its way back in because the Pleurovac has got a seal. And now we can fill the air leak chamber with the sterile solution that's on the back of the Pleurovac, and we'll show you that next. Okay, so now that we've got the new Pleurovac hooked up and the patient is safe again, we're going to, if we go to the back of the monitor here, there's a syringe attached that's taped in place. I'm just going to remove the syringe. And we're going to use this syringe. It's already pre-filled with 20 cc's. We're going to put it into this needleless injection system. And this is what's going to fill up this air leak meter to let us know if we have any air leaks. So this can be done after we're connected to the patient. And you can see how it fills up on the bottom and turns blue. And now we can just remove this and we're ready to go. So now the new Pleurovac is connected to the patient. The old Pleurovac can be discarded, set aside until you arrive at the facility, and you'd monitor the new Pleurovac the same way you did the first one. If you have any questions regarding this, contact your clinical manager.